Good afternoon, everybody. And on behalf of Palliative Care Queensland, we welcome you to our Palli Wellbeing Education webinar today, series for health professionals. So I'll just introduce myself first in case people don't know me. John Harboreg's my name. I've had a long involvement with PCQ over the years, and currently, I'm sitting in the interim CEO position while we recruit for a new CEO. So I'll just begin by acknowledging the traditional owners of the land upon which we stand. In my case, it's the Yagara and Turrbal people, and pay respect to their elders past, present and emerging. And we extend that respect to Aboriginal and Torres Strait Islander people here today. I'll just talk about PCQ's purpose. We believe that the way we care for our dying is a significant indicator of the values of our society. And our organisational priorities are that all Queenslanders are able to live every day until their last, to have a dignified death regardless of illness, age, culture or location, and have access to supportive social network at the end stage of life, and the choice of holistic, quality and culturally appropriate palliative care. I'd also like to acknowledge our sponsors today and supporters. So in particularly, the Palcare software company is a strong supporter, and the Connecting End-of-Life Care in Townsville project, which is supported by funding by the Northern Queensland Primary Health Network, which allows health professionals working in the Townsville area to attend today's session for free, and also the Ambulance Wish Queensland program. And again, that allows ambulance service paramedics in Queensland to attend this session for free. Just a little bit of housekeeping. For those of us unfamiliar with Zoom, and I think that's very few of us these days, I'd like to point out the following features that you may find useful. If you hover your mouse over the bottom of the page, you'll see a number of functions, including chat and the Q&A functions. Excuse me. The chat function can be used to make comments or give feedback in real time. Please ensure that you select the correct audience when sending a chat. For example, you can select panelists only or all attendees and panelists. So to test this function, we'd like you to send us 2 bits of information. Firstly, we'd love to know where you're from. So you can write that as a suburb or the Aboriginal and Torres Strait Island land that you're logging in from today. We also ask that when you send questions to our panelists, you send them via the Q&A function, not the chat. We have some dedicated time at the end of the webinar for questions, and we'll try to get to as many as possible. But if you put them in the chat and not the Q&A, I might miss them. Also, we'll share a link and a QR code for evaluation. Please ensure that you complete the evaluation. It's very important for improving our presentations, but also in terms of the statistics we're able to generate for our funders to be able to say how many people completed the evaluation. Now, just in terms of today's webinar, the topic has come from the PCQ Annual Summit in 2021, where we identify the importance of updating the healthcare workforce on the palliative care projects taking place at a national level. Excuse me. The results of the roundtable and key improvement areas are published in our 2022-23 Palliative Care in Queensland priorities, and they can be downloaded from our website. And there should be a link in the chat if you're interested in doing that. And they should also be listed now on your screen. So in terms of how today will work, first we'll hear from Professor Jen Tiemann and then from Emily Berwick, co-presenting with Anna McPherson. Please feel free to type into the Q&A or chat questions during this time. At the end, we'll open up for a Q&A and I'll facilitate and ask the questions and any that we've received beforehand. So let's get started. Professor Jennifer Tiemann is a Matthew Flinders professor and the inaugural director of the REPAD Centre in the College of Nursing and Health Sciences at Flinders University. I did do my homework, Jen, and looked up what REPAD means, but it's gone out of my head. I'm sorry. Jen is also a Care Search and Palliative Director. She's a co-lead of LDAC, End of Life Directions in Aged Care, and Director of the Knowledge and Implementation Hub of ARIA. So over to you, Jen. Thank you so much for coming along today.
Thanks, John. And I quite like the idea of being a processor and not a professor. So look, I'm here talking about Care Search today primarily and providing an update on the work that we've been doing over the last year. And I'm also going to be touching on a new strategy that we have with our partner projects. So next slide, please. A quick overview of what I'm going to be talking about. Firstly, I want to acknowledge that I am in Adelaide at Flinders University and I am meeting on the lands of the Kaurna people, and I'd like to pay respects to elders past, present and emerging. I would like also then to situate Care Search within the National Palliative Care Program, because I believe it's part of the project update system that's occurring, to talk about Care Search and Palliative, which we run directly together, and our partner projects. And I'll be touching on some of the key updates that have happened in the last year, including the release of the new portal, the Evidence and Translation Centre and our Palliative modules, and a new approach where we're starting to package resources to encourage uptake and use by individual health professionals. Next, thanks. So functionally, Care Search provides nationally available websites that aim to connect health professionals and the general public. So those people that need palliative care information because they're a patient or carer, or they're affected by grief, aging, dying, and caring. And we want to be able to make all of those people, health professionals and the general public, with access to evidence-based information and resources about palliative care. Next slide, thanks. But I want to also just talk about some of the things that have been driving our change in thinking over the last couple of years. One, we know that the demand for palliative care is increasing, and that's reflecting our ageing population and also the prevalence of cancer, other chronic diseases, while we have also what is the underlying interrupted life course dying that specialist palliative care particularly has been involved in. And we know that palliative care can be needed at any point across the life course, from birth, unfortunately, in adolescence, in the middle years, and then, of course, through ageing, right through to quite advanced old age. And increasingly, palliative care is starting to be seen in almost all settings of healthcare. In general practices, acute hospitals, residential aged care, community aged care services, and also generalist community services. And even more than that, which means that all health professionals have a part to play. We have a part to play with a diverse population where there's differing views and backgrounds and expectations around what happens in the care that is provided. So that means there's a lot of diverse evidence, information and resource requirements across those different groups and sections that are involved in providing care for an increasingly large proportion of people coming to the end of their life. Next slide, please. So where does Care Search sit in relation to what we keep talking about in terms of national projects? Well, policy relates to strategies and to national documents. So there is a national palliative care strategy that was released and endorsed by both the federal and the state and territory governments in 2018, and that's been shaping directions in palliative care nationally. It's also supported by an implementation plan and a monitoring and evaluation plan. And within that, there is the funding for a range of national palliative care initiatives and programs, which have a focus on education, training, quality improvement, and advanced care planning. And that's where we situate. Next slide, please. So Care Search is one of those names that's been around for a while and many people know it. And Care Search has sort of grown over that period in terms of the volume of information that provides. And functionally, we provide information that goes across the life course, across the health and aged care systems and community systems, and across the diversity of the community. And we do that through Care Search and through a sister website that we run directly called Palliative. And Palliative has a specific responsibility in regard to evidence for the aged care sector, both the residential aged care and the home care sector in ageing. But we also as well have formal partner relationships with a number of different projects. And that gives us a chance to actually look at how we can enhance the reach of our work. And so we work with the Advanced Project, which is working with primary care, and more recently is now providing dementia supports. We're part of the consortium delivering carer help, which is actually focusing on supporting carers in the community who are caring for someone who has a life-limiting illness. We are a partner in the LDAC project, and Flinders is a co-lead for that project. We work with the Caring at Home group in delivering their materials, and most recently their Aboriginal and Torres Strait Islander materials. We actually work with End of Life, POCA, and Talking End of Life, which is for people with intellectual disabilities. And by working in partnership, we can actually extend the quality of the work that is occurring and actually then use those networks and make sure we're informed across those processes. Next slide, please. So what I'm going to do is, so I don't make the partners feel they've been left out, is give a really rapid fire update on what some of our partners are doing in this space. So End of Life Essentials has released new learning modules, and some of them have come out very, very recently. And there's educator resources coming in the very near future. Carer Help has released an information pack for services, which so specialist palliative care services and GPs can order that to make available to carers that they are working with, caring for someone at the end of life. And diversity resources will actually be released next week, so stay tuned for that. LDAC is obviously continuing the very successful linkages program. We're right in the middle of something called the My Care Matters campaign, which is actually talking to the aged care sector around end of life as part of their care. And we released recently a self-care room, and coming very soon in November will be a dementia toolkit, but also a home care app for care workers. The Advanced project has extended its reach from the GPs into dementia clinicians, and care worker materials will be released soon. And the Caring at Home has obviously released the palliative care clinical box after a long consultation with the Aboriginal and Torres Strait Islander community. Next slide, please. So one of the things that we did, when the biggest things that Care Search has done in a long time, is to say in 2021, we undertook a major redevelopment of the website. And that was based upon engagement with the community, the sectors and health professionals. And what we wanted to do was make sure everyone was supported to be informed and involved, and that basically there was no wrong door that you could come in when you were looking for evidence. That led to a three-structure portal structure, which is community, evidence and health professionals. We want to just tick through the next two together or deal with them. Okay, so what's happening underneath is we have a transparent and a very rigorous quality process, which actually ensures anything that you find on Care Search has actually been reviewed based on evidence, assessed with health professionals, and then tested in usability assessment as well. Next slide, thanks. So this is just some components of what is happening in the community centre, which has 4 hubs associated with it. It has a patient and carer hub, Older Australia, because we've recognised that the ageing of the population is starting to influence the community and dying processes. diversity, and we also brought in what was our MOOC into an open access Dying to Learn hub as well, which is about normalising dying and enable people to think about it in different ways. We've actually also started to think, as well as providing content, about making it more accessible in different forms. Hence, we're looking at modules, booklets, videos, and we're also developing specific products. One of the examples there is books for children and also for adolescents. Next slide, thanks. Just trying to keep an eye on time. We have a large section that is related for health professionals, and this has been reworked. And I guess many of you would have been familiar with this part of Care Search in terms we have a lot of information that supports health professionals in different settings. And the anticipatory care is an example of the type of content we have, and we have hundreds of these pages which relate to particular health professionals, particular settings of care. But we've also been increasingly looking at the question of usable resources for people. So what I put up is some examples of how people can actually take things offline or use them directly. So for example, we contacted SPICT about supportive and palliative care indicator tool, and have actually developed that as an interactive form. We've actually taken MBS items, not just for GPs, but also for allied health professionals and for nurse practitioners, so that they can understand when they're working in palliative care how to pull together the MBS support in terms of their time use. And we maintain the checklist for an expected death at home for GPs. And down the left in the green, you can see the range of health professionals: GPs, nurses, allied health, support for Aboriginal and Torres Strait Islander care, health professional education. Under settings of care, you will find acute, you will find primary health, you will find paediatric, and you will find a small section on aged care, because we refer pretty much directly to LDAC and to Palliative from there. Next slide, please. So what I'm going to spend a little more time with you today on is the Evidence Centre and what we've done in expanding that. And that's actually really been in response to a lot of interest from the community about how do we not merely have available evidence, but how do we actually use it, and how do we have it in context where it can be used. And that forced a major rethink for us. And when we released the Care Search portal last year, we only released half the Evidence Centre because it took a longer period to develop. So the rest of the Evidence Centre was released in May, June this year for that. And what it seeks to do is make sure that evidence is there for your purpose. So there's practice-ready evidence to support health professionals. There's the capacity to search for specific evidence when you have a question that isn't answered by the summary materials. There's also resources that support your development in understanding evidence and practice, evidence-based practice. But more importantly, there's also now starting to be training around translation. So how do I, as a health professional, incorporate it into my practice? And more importantly, how does it flow into organisations, services and systems? And so what we've started to do is pull together the evidence translation theories, models and frameworks, and to start talking about how you can access core activities such as dissemination, planning, implementation, evaluation and sustainability. Next slide, please. So practice-ready evidence, I mentioned before. So what we're trying to do is connect people to high-quality evidence in the fastest way possible. So palliative care guidelines, there's lists of guidelines that are dealing with common issues, and we have them at the state and the national level. We have then, what we've always had is the clinical summaries. So we've taken the key topics that practitioners have told us about, pulled together review information on systematic review processes, have that available with key messages, the links to the systematic reviews themselves, so you can see the quality of the materials, and links to resources. Within the health professionals, we then take that and actually connect that to what's actionable resources for health professionals to use. So, and I've given just some examples of we've had prescribing resources, and that drills down all the way to medicines from the PBS prescribers bag for terminal phase symptoms. So this is about actually taking evidence and making it available for health practitioners. Next slide, please. Searching for evidence. at some stage in everybody's life, there is going to be a point where they need to find specific evidence, and we're trying to make it as easy as possible. We maintain a review collection for palliative care across dozens and dozens of topics, and there are hundreds and hundreds of reviews that could inform your need. We also maintain PubMed search filters and quick search, and what that enables you to do is basically have one-click searching into PubMed so that all the effort is done. You can click on it, you'll find information. And if you're not fortunate enough to be linked to, say, a university, you can actually then just select a free text option, which gives you the materials you can read immediately. We also maintain grey literature on what's happening in Australia, and we just have a running reporting on what's the latest Australian research that can inform people. Next slide, please. Evidence training. This is the basics of building evidence-based practice for health practitioners and for some people who aren't sure about it. But the most important thing, it's contextualised within the palliative care context. We also give some information for what you can do locally, such as set up a journal club, and useful tools for you to write a search for people who are less familiar with some of the aspects associated with evidence-based practice. Next slide, please. Translation. This is where we are starting to help people to understand what does it mean, how do I start to put together strategies, tactics at perhaps an organisational or service or a team level. So we have a lot of resources that are embedded within this information that can be downloaded and pulled out. We also have some learning resources, learning module resources, and most importantly, we're interested in having a conversation with the sector about whether there's something specific about the palliative care context that actually requires different implementation strategies. Next slide, please. So it would be totally unfair for me not to mention Palliative at this stage, particularly as aged care is such a key influence at the moment in healthcare provision. So Palliative actually had its origins in replacing what were the APRAC and the Compact guidelines to be a living evidence resource for the sector. And that's why there's a continuously updating evidence centre. But we've also linked that to a practice centre. So the sense of what can I do, what can I learn, and what can my organisation do for all of those topics. The key new resource we've introduced in the last 18 months has been the Palliative practice tips for nurses and for care workers. So we originally did this to try and pull together the individual training so that they were on one-page leaflets, which were very popular. But we then had the opportunity to turn them into a printed booklet. So there's been quite a strong demand for these within the sector. And coming back from the residential aged care sector and the home care sector was this idea that it would be great if there was some way that people could learn. And that led to the creation of what are called the Palliative introduction modules for aged care. So these are short, sharp, 10, 15-minute modules. They're not intended to be vocational training, but they give people introductions. They're supported by a Palliative practice introductory module, a module guide, which tells people how they can use it. We worked with a couple of aged care chains in developing this material, and I had very positive feedback. We've had about 20,000 module views since these were released about a year ago. With that, so next slide, please. And I promise I'm coming to the end, so I won't talk forever. The other component of what we're doing is actually creating resources that can be used. So there is a lot of material on care search. We've always known that. And what we're now trying to do is organise that against needs and groups of needs. So what I've given here is 2 examples of the type of way that we're shaping it. So in Palliative, there's a section where you can go to and order practice resources. And these were the practice tips I mentioned before. But there's also a cluster there is forms for your practice. So there's a whole cluster of forms around, for example, running a case conference. The other key thing we've done in Palliative, I didn't mention before, the modules that we have available, we run them through the Care Search and Palliative website, but we also have them available to download into a local learning management system for an aged care facility itself to do that. And then we've now started introducing into Care Search resource packs. So pulling together, for example, what are the forms that a GP might use and how can we cluster those so they're available for a single download or to order for printing. So these materials are now have been organised. We're starting to release them at Chronoplus last week and will be today at ACPA, so that these will now become more currently and widely available. Next slide. And I guess really in summing all of this up, there is a lot of discussion about everybody has a part to play. And so, you know, end of life is no longer the province of specialist palliative care. And what does that mean? It means all health professionals are going to be touched with the need to actually have an engagement in caring for people who were coming to the end of their life, regardless of their setting of care and regardless of their professional background. So Care Search also has a part to play. And what we've seen as our part to play is being able to provide trustworthy information for health professionals to make available to patients and families. We want to make available evidence that can guide your care regardless of setting and topic. We want to support you in building those skills around evidence-based practice and translation. We are packaging resources that can help you to practice, and they are free to access, and being online, they are available when needed. And I think I might be coming up to my last slide. So really what I wanted to take you back is right to the beginning. There are no wrong doors when you come in looking for evidence on Care Search. We have created a community centre, a health professional centre, and an evidence centre to help people navigate quickly to where they want to go. The evidence that we curate, we create, we evaluate underpins all the work that we do in both the community and the health professional sections. There are no exclusions. We don't lock people out. We just try to guide them as quickly as possible to the evidence and knowledge they need. And thank you very much for your attention. And I'm looking forward to lots of questions.
Thank you so much, Jen. I'm always in awe of everything that you encompass: Care Search, Palliative, etc., etc. So thank you so much for a great presentation. I'm delighted now to introduce you to our second speakers. So Emily works with the Palliative Care Outcomes Collaboration, or Peacock, as an improvement facilitator for Queensland. Peacock, as you may know, is a national initiative funded through the Federal Department of Health. It aims to improve palliative care outcomes for patients, families, and carers. Emily is based at the Cancer and Palliative Care Outcomes Centre at QUT and brings passion for good quality palliative care from both her personal and professional experience. Her clinical background is in speech pathology, and she has extensive acute hospital experience, particularly in palliative care and oncology in metropolitan, regional and rural settings. Emily also holds a postgraduate qualification in health management. Our second speaker, Anna, has a Bachelor of Science and Master of Public Health and over 10 years experience in health system strengthening, research and program management. She's previously worked in developing contexts, including research for the Asia Pacific Observatory for Health Systems and Policies and the Health Information Systems. Sorry, I think I'm missing something. Health System Knowledge Hub, as well as in health promotion and clinical trial management in Australia. Excuse me. Since 2016, Anna has worked as an improvement facilitator with Peacock, and we're delighted to have both Emily and Anna today. So over to you both.
Thanks, John. Hi, everybody. I hope you can hear me okay. If not, just let me know. So as John said, my name is Emily Berwick and I'm here with my colleague Anna McPherson. And we are the improvement facilitators for the Queensland jurisdiction as part of the Peacock project. We'd like to thank Palcare Queensland for inviting us to talk about our project today. And before we get into our slides, we'd also just like to acknowledge the traditional owners of the lands on which we meet today. And I would like to pay my respects to the elders, past and present, and I would like to extend my respect to the Aboriginal people, colleagues and staff who are present today. So a bit of an outline, we'll give everybody a bit of an overview as to what Peacock is, but then we'll talk through the last data results for the last 6-month period to let you know what that looks like. So next slide, please. So just an overview of Peacock. So Peacock is a national approach towards the routine assessment in palliative care practice. And we use standardized and validated assessment tools to improve clinical outcomes. So overall, we're an integrated outcome centre. We are funded through the Australian Government Department of Health, like other palliative care projects, and we've been in existence since 2005. And we're a collaboration between 3 different universities. So myself and Anna sit with QUT, and our chief investigator is Patsy Yates, Distinguished Professor Patsy Yates. And the University of Wollongong is the lead site. Next slide, please. So in relation to a data coverage for Peacock, we're the largest longitudinal database internationally, and we collect outcome and demographic data. And that data feeds back to about 16 years, and we've got data nationally on 250,000 episodes, and we provide data on a range of different demographic and outcome related measures that can be used to change policy, shape research, build business cases, and that type of thing. And so the program is voluntary, and across Australia we've got 95% or about 95% of our Australian specialist palliative care services participating. And then in the graph, you can see the growth of Peacock, that we've had a substantial increase over the last many years in terms of patient numbers and sites that we've brought on board. So next slide, please. So just in relation to what our aims are, so overall, Peacock improves national hospice and palliative care service symptom outcomes systematically through point of care data collection, structured feedback and benchmarking. We also improve or aim to improve palliative care outcomes for patients, families and carers. So key to Peacock is that we acknowledge the family and carer as part of the unit of care. And we improve those patient outcomes through standardised assessments at point of care data collection. We also facilitate service-to-service benchmarking. So we provide benchmarking at state and national levels. And like I said on the previous slide, we use our data to then support research, shape policy, achieve system level improvements, and overall drive quality and outcome improvements. So next slide, please. So before we talk about what our data shows for the last 6-month period, we thought that we'd just give you an overview of the benchmarks. So within Peacock, there are 20 benchmarks. And so we've got one benchmark that looks at the timeliness of care, one that looks at responsiveness to urgent needs, 6 that look at pain management, 9 that look at symptom management, and 3 benchmarks that look at family and carer problems. Next slide, please. And so for the last 6-month reporting period, specifically looking at our Queensland participation, so that period is January to June 2020. We had 26 services across Queensland in total participate in Peacock. We're capturing private and public services as well. And of those 26 services, 13 of our HHSs within Queensland Health are participating. And our data spans across inpatient, consult and community settings. And so in terms of our patient numbers, there were 3,183 patients in the community and just over 2,300 in the, for inpatients, and then in the community, 2,335, which is quite a big increase from our last reporting period prior to that, where we saw an increase for this time by just over 670. And that's probably reflective of the fact that we brought on quite a few new services as well. With one of them being quite a large service, being Metro South Community. So next slide, please. Okay, so here are our benchmarks. So you can see on the left, we've put the Queensland benchmarks And then on the right, we've got our national benchmarks. And so we've got the 20 benchmarks listed. And then just in terms of interpreting this, when the benchmark is colored green, that means that it's been met. And when it's orange, it means it wasn't met. And the red line is where the benchmark is set. So for the top few, it's set at 90%, and then the bottom couple, it's set down at 60%. So what we can see for Queensland is that we met 16 of the 20 benchmarks for the inpatient setting, which is quite comparable to the overall national results, where 17 out of 20 were met. And what these benchmark results show is that people that needed palliative care or needed an episode to start, 99% of those people had that begin on the day or day after needing that to occur. We could also see that the majority or all of our anticipatory care benchmarks were met. So for those 20 benchmarks, we've broken them down into anticipatory and responsive care. Anticipatory, I guess, means or reflects that kind of bread and butter palliative care. So that's where you understand the patient's condition, you understand the trajectory of where their disease is going to continue to decline to, and you anticipate any symptoms or problems that might occur, and you address them before they escalate. So this is looking at people that have either absent or mild pain, fatigue, breathing problems, and family care problems, and measuring where the service was able to keep them at bay and keep them to that absent or mild level. Whereas responsive care benchmarks is where the individual had moderate or severe scores in those domains, and then there was a responsive or a response needed to get those symptoms better managed, so to bring them back down to absent or mild. They're usually harder to meet because of that nature, that you're reacting and responding to an urgent need or an escalation of symptoms. And so we can see for Queensland, we didn't quite meet them for fatigue and breathing problems and family and carer problems, but we were close. We were within the 10%, so not too far off the 60%. And we'll move to the next slide, which Anna will talk to.
Thanks, Emily. Okay, so this is the same results presented with Queensland on the left and against the national comparator on the right, but for our community cohort. So as Emily said previously, we have, I think, around 10 or 11 community services participating in Peacock in Queensland. You can probably see at first glance there's a lot more orange across both of these dashboards here. So that shows that those benchmarks were not met, both in Queensland and nationally. And it's really important at this stage to explain that the Peacock benchmarks are set to be through a patient's eyes. So they are the same benchmarks for both inpatient and community settings. However, obviously community settings don't have the sort of 24-hour resourcing, access to medications and medical input that inpatient settings have. So you can see that the average is that the community services don't achieve as highly against those benchmarks. I'd also like to point out the benchmarks are sort of an aspirational target in a way. So it's not realistic that some services will meet the benchmarks, but it is still important as a record of achievement, so services can look at continuous quality improvement. Sorry. So sorry, I'm getting phone call there. So you can see here Queensland met 3 of those benchmarks compared to 7 for the national average. But Queensland and nationally, we were close to several of the benchmarks. Particularly, you can see the anticipatory care community services are performing quite solidly, putting in place a good anticipatory plan to support their patients. The responsive care is, of course, more challenging in the community. We'll move on to the next slide then, please. So this is just to give you a little bit of a profile of typical patients in the Queensland dataset. So the graph up on the left there shows the breakdown between diagnosis malignant and non-malignant. So in this last report, we had around 35% of patients across both settings had non-malignant diagnoses. And that has actually increased by about 10% over the last couple of years, which represents that Peacock has been able to support and represent some of the data of the services that are consulting into residential aged care facilities, really. And we've been involved with the SPACE project in some of the Queensland HHSs as well. In terms of the sex there, you can see there's slightly more males in the data, and the average age at episode start is around the mid-70s there. The table over here then shows just a few characteristics comparing Queensland and nationally. So you can see that in terms of diversity, we had around 2% of our cohort were Indigenous, Aboriginal and or Torres Strait Islander, which is slightly higher than nationally there at 1.7%. We do, however, have about 5% of items were not completed for that Indigenous data item. So we're always encouraging our services to sort of get the most complete data they can and to really represent their population. In terms of country of birth, Queensland has slightly higher representation for Australian-born participants, and similarly with the preferred language, there is 90% or 93% English for Queenslanders compared to 87%. Across both Queensland and nationally, the primary malignant diagnosis was lung cancer for about 13% of patients, and the primary non-malignant diagnosis there is cardiovascular disease for about 5%. Next slide, please. This shows you a little bit about referral patterns and where patients are coming from and ending their episodes across the inpatient and community settings. So you can see here the referral source for the inpatient palliative care episodes tends to be from hospital, both in Queensland and nationally, whereas in the community, it's about half of that referrals from hospital, and then that's followed up by community palliative care is the next highest referrer for inpatients. And for the community, it tends to be GPs and the next largest cohort of referrers, followed by specialist medical practitioners. In terms of episode start, for the inpatient setting, about 2/3 of patients are coming from their usual place of residence, so from the community, whereas in the community, we've got about a little bit less proportion of the patients are being admitted from inpatient palliative care compared to the national cohort there. And then in terms of episode end, for inpatient settings, about 50% of the episodes end in death. And in the community, it's about 1/3 of the episodes ending in death, and the other main episode end mode is that the community patients are admitted for inpatient palliative care. Next slide, please. Okay, so this information is again off the dashboard, which is sort of a high-level summary that we produce for services. And this is just the Queensland data here. So firstly, you can see the episode length for patients is about 8 days for the inpatient episodes and around 35 days for in the community settings. The graphs here then represent the most significant problems and issues for patients at the start of their episode. So you can see here for inpatients, the most bothersome symptoms in terms of the patient-reported ones here are pain and fatigue, affecting about 20% of patients, or being moderate or severe, sorry, for about 15 or 20% of patients. From the clinician-reported symptoms, again, pain and other symptoms, which is a mix of other physical symptoms, similarly affecting about 20% of patients at the start of the episode. In the community over here, you can see fatigue is really the most bothersome symptom for patients, and that's affecting about close to half of patients in the community reporting moderate or severe fatigue as problematic. Next slide, please. I've just got a couple more just to give a little bit more of an overview of some of the other areas Peacock's working in. So Peacock is committed to helping provide education. We have a range of different education resources available. So our first sort of protocol that we say is good for new services or new clinicians is an online short course, so that clinicians can do that in their when it suits them. So that's got a couple of modules that can be done online, and it only takes sort of maybe 40 minutes or something to complete that. We then have been moving towards webinars post-COVID. We've sort of haven't gotten back to doing a lot of face-to-face education or seminars, which we used to do in Brisbane. But we now have a range of different webinars targeting different levels. So we've got a fundamentals, which looks at how to understanding Peacock and the basics about using the 5 assessment tools. The next step up then is for clinical leaders who will sort of have a training role in their service, and that helps them to look at how to really embed Peacock, the assessment and response framework, into their routine practice. And then the advanced level is for services to really understand how to use their Peacock reports, understand the data, and to then use that for quality improvement. There's more detail about that on our website address, which is at the bottom there. And I think we've got one more slide, just a little overview of some of the resources we also have available on our website. So we have quite a few resources around quality improvement. There's an example here of a guide that we have, but we have also templates and tools which are helpful for services to undertake review of specific cases, to look at practices and do some retrospective auditing of some of their assessments. We also have mapping to the National Quality and Safety Accreditation Standards, and we have quality improvement reports which have been generated by services when they've undertaken a quality improvement activity. We ask them to document that, and then that's shared amongst services. And the last slide is just our contact details.
Okay, thank you so much, Emily and Anna. Now, questions. We have only one question in the Q&A so far, so please put any questions in there that you might have, people. So the question in the Q&A is obviously for Emily and Anna. Do you have any data on people living in rural and remote areas?
Yeah, so within our data sets, we do capture people's postcode. So if somebody specifically wanted to look at, I'll just give it an example, people that live in Charters Towers, for example, that are travelling to the Townsville Hospital for palliative care, we can, with data requests, we can map that postcode. But then we also have some services that are onboarded with us that are situated in those areas. So for example, Mount Isa is involved in our program, which is a rural and remote location. So there is different information that we can pull.
Okay, thank you for that. I've got a question for you, Jen. Did you notice any change over the period of pre-pandemic, going through the pandemic, and now starting to come out the other side? Did you notice any changes in the way that people engaged with Care Search and the other programs?
Yes, and we also directly picked up some COVID issues as well. So we actually found, we introduced COVID resources into Care Search quite early on in it, and joined with Palliative Care Australia on their working group around the response to COVID. And one of the things we found, that there was an enormous response in the very early period to try and be able to find material that would support care, particularly in the community. And I think what happened was a lot of people were retreating to their homes, including people who had palliative care needs and their carers. And so the question then, they didn't want to have people in the houses, and they needed to know how to try and do some components of work themselves. We also worked, for example, with Caring at Home, which had actually been looking at providing kits and training for family carers to support medications in the home. And so those types of components were really critical in those elements. And we also worked with both LDAC and Palliative in terms of providing COVID material for residential aged care and for home care package people, because that was obviously a critical area of need for that. All of the indications in terms of people visiting or people downloading suggest that there was very strong usage of those materials. And I think then the other components that we're doing over time as we're looking at it is, we've been working with groups who are doing research into the areas. So for example, Liz Lobb's work, we're doing some work with that group who are looking at bereavement and COVID to try and identify what will be the issues that may sustain going forward in addressing and supporting people, with some indications that bereavement has been made more difficult and complex by COVID. And I think the other component that really we are considering now is really withdrawing some of the COVID information we have, but maintaining the avenues for access to research and evidence about COVID, and actually looking at what does pandemic and emergency preparedness really need to look at. And to some extent also encouraging palliative care to think about the issues on what role should palliative care as a discipline, what role should health professionals working, and what role in specialist palliative care, but also what role would health professionals themselves who are caring for people who may be in the last year of life need to do to support them in terms of emergencies. And I think, you know, we've seen floods, fires, and a pandemic. I think we need to consider how this affects us as a specialty, as an area of care, given the proportion of Australians who will be heading into the last years of their lives.
Thank you, Jen. With the backup of Care Search, we should be very well prepared for those eventualities. Whether we are or not, it's another matter. Jen, a question for you from the Q&A. How do healthcare professionals receive training in aged care? I assume that's palliative care training in aged care settings, and it's part of their mandatory training, ?
This is actually a relatively complicated question and answer in many different ways. I think vocationally, obviously, nurses who will graduate will have had some level of exposure to palliative care and end of life in their training, but perhaps not as high a degree of practical hands-on as if they've been 2 or 3 years after graduation. And the government does provide transition training for nurses in those areas. In response to the Royal Commission, the government has actually seen that palliative care training is required for health professionals and aged care staff working in aged care, because we also have a large number of care workers who may not have health professional qualifications, for example. And so at the moment there is discussion about actually bringing in a greater requirement in their Cert 3s and Cert 4s to be exposed to basic principles. We are very fortunate to actually have had a series of projects and programs that are actually working with aged care and providing resources and materials to that. So obviously LDAC is a critical component player in that group, and that enables, through the linkages, the opportunities for services to connect. Palliative has actually produced materials. Peacock, which is a sister project for Peacock, has also got materials that will come through over time. There are also a series of other providers of materials and resources, and a number of the aged care services themselves have recognised the need for this and have been creating different sets of materials. And I think the important thing is about getting consistency of messaging around what the best education, or the most appropriate education for the different providers within their scopes of practice, and that covers what we see to be the principles for it. Is that enough? Otherwise I'll go on for hours.
That'll do for now. Thank you, Jen. Thank you. Another question for Emily and Anna. Where is the information available about Peacock? Do you have publications or a web page where we can find this? Actually, if you could put it in the chat, would be great. Excellent. And while Emily or Anna are doing that, I've just got a question. You referred to the fact that families and carers are an integral part of the care unit in palliative care. Does Peacock have any plans to gather data about families and carers rather than just patients?
Do you want to talk to this one, Anna?
Yeah, we have been investigating collecting further data about bereavement for a long time. It is a complicated area to move into because it is provided very differently by different services. And the main difficulty for us in Peacock is that it requires a different record. So we just get records from a patient, and then we don't have any way of attaching sort of a new patient as a family member or a bereavement service recipient. So at this stage, we don't have any plans to, unfortunately, be able to follow that data. We have done in the last, I think it was last year or the year before, we did a patient and family carer experience survey. So we were able to get some qualitative data through that around family and carer experience. Okay. Did you have anything to add to that, Emily?
No, I don't think so.
All right. Okay. Thank you. Thank you very much. Well, we're running out of time. I don't think there's no other questions at the moment. And Anna, thank you, and Emily, for putting the information there in the chat. So it's time for me now to thank our speakers, our wonderful behind-the-scenes staff for making today's event happen. Thank you to our volunteers for creating and supporting the event along with our staff, to our fantastic speakers, our sponsors and supporters for making the event possible. And thank you to you who have taken the time to come along, listen, learn, and engage in this space. We hope it's inspired you to champion some key improvement areas in your area of work. So what next? You will receive an evaluation after the session, and there's a QR code just come up on your screen. There will also be a link in the chat. As I said before, we would really appreciate if people could evaluate the session. If you would like to request a certificate of attendance, please email hello@palliativecareqld.org.au, and that should also be in the chat. And we will also send you a virtual copy of the project report. I'd like to close with a reminder that PCQ is a membership-based organisation. It's only $75 for individuals to join, or $300 for organisations. Individually, we can make a difference, but collectively, we can really advocate for change to ensure that all Queenslanders live, die, and grieve well. And I will probably get into trouble if I don't mention the Ambulance Wish Queensland dinner. It's coming up on the 4th of November. It's our main fundraising event for the year for Ambulance Wish Queensland. So for those of you in Brisbane or not too far away, if you were able to get there, that would be fantastic. So just go to the PCQ website and there'll be information there about it. So thank you again, Jen, Emily, Anna, really appreciate your input, and thanks everybody for coming along. Okay, bye.